From my standpoint, I would do a lot of tests with you. I would check your vitamin D status, I would check your iodine status, we look at your AMH. We know that women who have been diagnosed with endometriosis are more likely to have a lowered AMH, which stands for anti-Müllerian hormone, which is one of the biomarkers of your kind of fertility lifetime. So, and that's why a lot of women with endometriosis do decide to actually kind of freeze their eggs. So, whilst you're on any other kind of hormonal treatment, there is definitely things that you can be doing in tandem to that. But that's why we would get any data on you so that we could be supporting you appropriately, so that you're feeling you're making, you know, the best decisions for yourself and your future, you know, fertility, health goals. Maybe you've got a comment around progesterone too.
I think a couple of things. It's important to differentiate between progesterones and progestogens. So they are two completely different types of hormones. Progesterone is what your body naturally produces. Progestogens are actually male hormone derivatives that have been made to bind to the progesterone receptor, but they also have other actions on other receptors. Having said that, from my understanding, there is no negative data for Visane. Visane is a new generation progestogen. It is not a progesterone. It has been changed to alter or enhance its actions on inflammation. Good studies suggest that it inhibits growth of the deposits to somewhat. And from both a biological perspective, like a theory perspective and a data perspective, there's no negative impacts on fertility per se. For people who, I think it's important to say, who understand your own fertility, I think also understanding your own goals. And that's one of the things I always talk to my patients about. You sitting here in front of me, what are you trying to achieve? Are we talking about pain relief? Are we talking about preservation of fertility? Are we talking about having a baby here and now and you've been trying for a bit of time? Doing that testing, doing an AMH level, for example, will help you make that decision. So, for example, if you know in your mind you would like a child sometime in the future, but your AMH is on the lower side, then you may actually switch tack and say, actually, I want to do egg freezing now. So I think having that clarity, and sometimes that clarity doesn't develop until you have a bit more information. So that's what I would sort of advise. But in terms of the negative effects of some of these hormones, I would probably say that you're in a good space with Visane. But the caveat to this is that a lot of these newer medications don't have long-term data, and that's something I'm very honest with my patients about. Visane, my understanding, has about a 5-year data range, and as more people use it, more data will come in. But from like a sort of first principles perspective, I don't see how that could affect your fertility. You certainly won't get pregnant if you are on it, just because what it does to the lining. But once you stop it, there should be, it's all reversible.
I would like to add one thing to this. From Chinese medicine point of view, I also don't see negative impacts from the Visane. So I would emphasize that your chances of pregnancy are not, we can't say, so it's pretty, it's also a very good chance that you won't have any issues at all. So that said, I always emphasize that you, once you decide to have a baby, that you just get off the hormones and then start trying without fear, without already expecting this will be an issue, because this just increases fear or anxiety, stress. And as I see that your partner's with you, one thing which is very important from my point of view is get the sperm parameters tested very early.
Unfortunately, you're one of the only blokes in the room, so we use that opportunity to be brainwashing you at any opportunity. Anyone who works in the fertility space, we do, unfortunately.
No, I just want to, so thank you very much for coming. I really want to make sure that because you can't be, as I said before my talk, you can't have if you go off the Visan, you are from Western medicine point of view, you are untreated, you don't have a current treatment. And we do not want to prolong this, this time to pregnancy if it's not you which is the reason not to conceive. That's why we are trying to get the sperm parameters very early, just to make sure there's no issue there. Because if there is an issue, we want to know beforehand. That's why I always recommend to get the sperm test done quite early in the journey, just to make sure, okay, there's no issue there. And if there should be an issue, we all hope there's not, then we can directly make another plan.
So thank you for your question. That's actually quite a complicated question. I'm going to try and answer it as best I can. So even up until today, the gold standard for diagnosing endometriosis is still a laparoscopy. When we're talking about 20 years ago, when laparoscopy first started, it was literally like the scope goes into the abdomen. It wasn't connected to a TV. You actually looked down the scope into this tiny little hole to try and diagnose endometriosis. So even if you did have access to a laparoscopy, the rate of pickup would be extremely low. As you saw from my pictures, even with a laparoscopy, you have to have such paranoia about finding endometriosis. You almost need to be expecting to find it to diagnose it properly. I've seen many gynecologists do this big sweep around and it's really quick and it's like there's no endo. So diagnosis of endometriosis in modern days is hard. So yes, in the 20, 30 years ago, I have no doubt that lots of endometriosis was missed. When you have a look at what the World Endometriosis Society says about endometriosis that needs treatment, it's not only necessary to have what you think is endometriosis, like for example on laparoscopy, but you also need to have symptoms, and that is the indication for treatment. So for example, if somebody has an ectopic pregnancy, we take out a fallopian tube and we find a spot of endometriosis and they're completely asymptomatic, they've finished their family, they're pain-free, then they technically don't need treatment. So my answer to your question about treating people with symptoms is treat their symptoms. So if they tell you it's painful, it's worth investigating. If they say it's not painful, we see how it goes. In relation to pregnancy, the reason why we think pregnancy reduces people's need for future hormonal therapy is because pregnancy is predominantly a progestogenic state. So for 9 months, your system gets flooded with progesterone. You get estrogen, but it's actually not estradiol, which is the active estrogen. It's estriol, which is much less active. You just get bucket loads of it. But progesterone is the main driver. So if you have pregnancies in short intervals and you have this overwhelming progestogenic influence, you do dampen that hormonal pathway of endometriosis growing. And in some people, endometriosis will definitely recur after pregnancy, but symptom-wise, it's enough. But in I'll probably say about 50% of people, it comes back. Either comes back very quickly or it didn't ever go away at all, which points to the fact that there are non-hormonal pathways that control pain, and we just don't know enough about it to actually treat that. Sorry, I hope that answers your question.
I also think having 4 children, and you may have had 4 breastfeeding experiences, would have also helped. So you having 4, wonderful that you conceived very easily, but having 4 children and having that length of time off estrogen and E2, which is the estradiol, would also just have that impact. So that's why we know the statistics show, that the more children, the more breastfeeding experiences, the more time that a woman has actually had a break off that kind of active form of estrogen, means that that could have really remedied or definitely plateaued any endometriosis that might have been kind of present for you. So.
I was just going to say a comment about the cultural piece that we're hearing, another person with endo, another friend with endo, and at least my age range is very common, sister has it, cousin has it, it's just popping up everywhere is what we hear. And I think that, as you've pointed out, how, people in earlier generations may not have known about it, it was virtually impossible to diagnose. I think that one thing that's quite promising is one thing we hear from our community of 2,000 young women is that they're still very pragmatic about the fact that period pain is also quite normal, as in, I'm not, again, medical practitioner, but we know that women are still pragmatic about the fact that pain does present itself as a symptom when you have a period. What they're getting more discerning and savvy about is when to access support, when to reach out, and educating themselves on when it might be time to actually understand if there's a diagnosis of any kind. So I just want to reinforce that we're hearing from young people and young women that they are very discerning and savvy and doing their best not to catastrophize. And we aren't seeing that across the board, despite it might feel everyone all of a sudden has it.
I think the one thing I'll just add, just to reinforce that, is that 99% of patients can tell you very accurately how that pain is affecting them. It really is. I think that sort of old school saying, oh no, that's just normal. If a patient is sitting in front of you saying this pain is affecting me adversely, it is affecting them adversely. And that's something I teach my registrars, my fellows all the time. You actually just have to listen to what's in front of you. The second thing is, the other thing that's a little bit hidden is adenomyosis. I suspect a lot of the period cramping that you get with endometriosis is probably concurrent adenomyosis. Certainly the pathology of adenomyosis fits that pattern. So that is that heaviness, that clotty kind of pattern in association with crampy pain. And when you actually talk to people, they will say that the pain that they have, that crampiness, is actually very different from when they don't have a period, which is a very different type of pain. So adenomyosis is a talk in itself, but it is common in people with endometriosis. It's extremely common to have adenomyosis and endometriosis, and you do get that cramping, and it's only really diagnosed in people who have the ultrasound skills to pick it up, and very few people do. So I have to say, even though I'm Western trained, in terms of managing chronic pain, I think there is enough evidence in the realm of acupuncture to say that it does help. To reset your thresholds for pain takes lots and lots of time, and these pathways are still not fully understood yet. Surgery, in my experience, for the type of pain that you're telling me about is not as useful as a lot of people think it is, because the disease is there, sure, and you get rid of it, but whatever has been done to your nervous system is already done, and that's actually what needs to be reversed. So my advice is actually to go to a complex, so there are gynecologists who subspecialize in pain. So for example, I'm a gynecologist, subspecializes in reproduction and reproductive surgery and all of that, but there are gynecologists who specialize only in pain. And they will work with physios, nutritionists, complementary therapists to actually do that. And that's probably what people like yourself will need, and time and patience. I mean, being reliant on a drip that gives you IV analgesia is not a long-term solution. And what we find with these patients is sometimes they do need, that kind of therapy as breakthrough, as very short things. And we're hoping that with enough intervention going on in the background, that the interval needed for these interventions are going to be longer and longer and longer, and at some point you don't need them anymore, and that's the goal, but time. Maybe I'll ask the second question first. Seems easiest. So the holy grail at the moment for diagnosis of endometriosis is a non-invasive way of doing it. So there is a lot of work going into biomarkers at the moment, biomarkers that are specific for endometriosis. There are one or two that are close, I think, to clinical sort of trials. BCL6 is probably the most hopeful one that's coming out of the States. Even that is still a biopsy of the lining rather than a like a blood test or something like that. So hopefully we will get there. At the moment, the guidelines, both Australasian and worldwide, will say that you diagnose based on symptoms, and you definitely don't need a laparoscopy. I think we're past the age where we do a laparoscopy just to diagnose it. I think for me, I do a look and treat. So if they warrant enough pain to do a laparoscopy, then it's a laparoscopic excision of endometriosis, not just a diagnostic. Endometriosis in weird regions, I would probably have a real good chat to your doctor, because endometriosis in lung, in brains and all of that stuff, it's extremely, extremely rare, and you're much better off ruling out other things that cause these pains. So if you have, for example, endometriosis in the chest, causes what we call pleuritic chest pain. So chest pain that is worse when you breathe in and out, and sometimes, yes, it comes with your period as well. But there are a whole lot of other things that cause this kind of stuff. So I think you are much better off, ruling those out, because they are much more common. In terms of HRT, or what's the name now is MHT, because HRT has such bad press now, nobody will want to take HRT. HRT or MHT has a huge amount of benefit in people who are going through perimenopause and who are postmenopausal. Its protective effects on the bone, the heart, the brain, maintaining normal sexual function, maintaining urinary function, all that is significant. Having said that though, in people who have severe endometriosis, I always do counsel them that there is a small chance that your endometriosis symptoms will come back. And my approach is, one, to avoid oral agents. I tend to not like oral agents purely because what happens when you take a pill is that it goes to your liver, and your liver gets rid of most of it, and therefore, for you to have adequate amounts in your bloodstream, you actually need to take a big whacking dose. You want something that goes into your bloodstream pretty quickly, and therefore you can give small doses. And in terms of MHT, it's actually gels, topicals. Patches and gels are really good for that. And the other sort of theory is that, the other sort of tenet of my practice is that you give the lowest dose possible to give the maximum effect. So I kind of start off with a medium dose, and I try to titrate up and down. And then I think all of us would probably see people reasonably regularly until we're happy that they're not symptomatic. And then at some point we're going to have a chat about, is MHT beneficial anymore? Because after about 10 years, it stops being as beneficial as you think. So just sort of having a practitioner who actually understands what MHT is important in that sphere. I'm not sure whether the other guys have a view on this.
I mean, just sometimes you can see women who have been, without a period for 2 years or so, and they can start to bleed again. So as Dr. Lee said, that's where we have to encourage them to titrate their dose, because that can be a concern for me. If they're like 2 or 3 years into menopause without actually a period, and they start to bleed again. So that's when you're concerned about the impact of estrogen on the lining of the endometrium.
I have to say, in my practice of menopause, I've never actually sent anybody back to the GP with no follow-up with me. I always at least see them at least once a year. I see them once every 6 to 8 weeks at the beginning. And then once and then I gradually space it out to 3 months, 6 months, and then once they're happy, I still see them on a yearly basis just to check in, because it's complicated.
You could also try other things, like I would recommend Chinese medicine for this. so you don't risk increasing your hormonal situation. And you can still treat the symptoms, because in my experience these menopausal symptoms are a mixture of things. It's not just the hormones, it's additional things like stress or like digestive disorders, and you can all address these with Chinese medicine as well, so you can have a much more holistic approach than just taking hormones. So I would maybe have a look into these kind of options to deal with the symptoms, and usually from my experience you don't need that long-term treatment. You usually don't need treatments like over, I don't know, 5-10 years. That's definitely not necessary. Usually this can be, I've seen many patients where I have conducted a couple of acupuncture treatments, but they took the Chinese herbs for a bit of a longer period of time, and then they just start reducing the dosage, and then they get off. So this is definitely also an option.
So the short answer is yes, there are certain associations with especially stage 4 endometriosis and pregnancy. So looking at sort of Scandinavian data and some Australian data, you would say that most peripartum complications are slightly increased with stage 4 endometriosis. So bleeding around your birth. Certainly rates of postpartum hemorrhage are a little bit higher. There are studies that indicate that abnormal placentas, so placentas that don't separate properly from the uterus, is a little bit higher. But they are increased, but they're not hugely increased. There are some studies that suggest that growth of the baby should be monitored quite regularly, just in case the placenta doesn't work as well. From a very, very practical perspective, I think needing an operative delivery is something that is always on my mind when I was doing obstetrics for people who have endometriosis, because if you needed to, if you were in a rush to get a baby out, an abdomen that is full of adhesions and endometriosis, you're not going to be able to do that quickly or safely. So as a result, operative deliveries, so cesarean sections, are higher in the endometriosis population. Now, whether that is because you have a very cautious obstetrician who says, look, as soon as there's something remotely abnormal with the pregnancy, they say, look, I just don't want to rush in the middle of the night to try and deliver the baby safely. Do we just do a planned cesarean section, or whether there is a true link to the delivery? We don't know. But there are, I would probably recommend, my inclination for people who have endometriosis is, I don't mind what kind of care you have, as long as it's not like a free birth at home, for example.
And potentially just looking at progesterone receptivity in that first trimester as well, that a lot of women with endometriosis, you might need to be using a bit more kind of progesterone locally and working with a specialist who would...
There's no harm in giving progesterone in this context. It's more the fact that from a monetary perspective, it's not covered by Medicare, but progesterone pessaries are probably one of the less expensive IVF fertility drugs that are out there.
And again, no harm, so...
No harm.
No harm whatsoever.
Makes you a bit more hungry.
Yeah.
I would like to add that Dr. Lee already pointed out that about 80% of women with endometriosis also have adenomyosis, and unfortunately adenomyosis is associated with a bit higher miscarriage rates. I'm sorry to hear that. So from a Chinese medicine point of view, I noticed that these women tend to have a bit more cramps in this early phase of the pregnancy, which is not ideal. And you can either try taking magnesium to reduce this. I also would definitely recommend getting acupuncture as well, because with acupuncture you can also diminish these cramps. And address maybe other underlying causes, so that's definitely a thing you could consider. I would recommend starting Chinese medicine before you are getting pregnant, because from my experience you can only treat like the remaining 10%. The rest of the treatment needs to be beforehand to really, because as I said, Chinese medicine is unfortunately slow, so you need to have a bit of a phase before. So